Good evening, all. Welcome to this session. We will try to see spotters mixed bag. We will try to see spotters, OSCE, and MCQs. I have been busy for preparing for the IRA National Conference at Vijayawada, so I was not able to upload the video for the past 2 weeks. So I was invited as a national faculty, even as a judge for oral papers, and I was one of the quiz masters for National UVA IRA quiz. So these are the few glimpses of it. So these are the faculty and judge mementos and certificate. So even I have presented a lecture on lesions of corpus callosum film festival. So this is one of the quiz master among all the 6 quiz masters. This is while conducting the quiz, and I have met eminent personalities in the radiology, both national and international level. And this is during the gala dinner. Met national level leaders and also important eminent personalities in the radiology. And even these are all my PGs, and also I have met students from other colleges. So coming to the first case, it is 12-year-old male presented with fever, followed which he developed weakness of bilateral lower limbs. So here you can see there is abnormal enhancement and thickening of the conus medullaris, and even abnormal enhancement of the anterior nerve roots of the cauda equina. So this was a case of Guillain-Barré syndrome. So this is nothing but a Guillain-Barré syndrome. What is the pathognomonic MRI feature seen in Guillain-Barré syndrome? It is surface thickening and contrast enhancement of the conus medullaris and anterior nerve roots enhancement of the cauda equina. Which cranial nerve is commonly involved in brain in this entity? It is facial nerve 7. So this is nothing but a autoimmune polyradical neuropathies where there is autoantibodies which is produced. Typically causative organism may be Campylobacter jejuni, and following fever or diarrhea they can develop a progressive weakness, that is acute flaccid ascending type of paralysis. Next, this is other double contrast barium enema case. So what is the diagnosis and what are the syndromes? So these are nothing but multiple colonic polyps. You can see multiple colonic polyps projecting into the lumen of the colon. And which of the following syndromes are associated with diagnosis of barium enema? Cowden syndrome, chronic Canada syndrome, and Lynch syndrome are associated, but Cockayne syndrome is not associated with colonic polyps. So these are, you can pause the slide and see all the polyps associated syndromes. So the answer is nothing but Cockayne syndrome, which is not associated with colonic polyps. Next, 17-year female with chronic history of epilepsy. So 17-year female with chronic history of epilepsy, mental retardation and multiple sclerosis lesions. What is the diagnosis? What is the clinical triad which is seen? And which of the following is not usually associated with disease? In this case, you can see there are radial white matter bands, and also there are even cortical tubers, and there are multiple subependymal heterotopic nodules or subependymal hamartomas. So this is a case of classical case of tuberous sclerosis. So what is the triad which is seen, which is nothing but Vogt triad or epilolia. Vogt triad is nothing but epilolia, that is EP means epilepsy or seizures, low means LOI is low intelligence, A is adenosebaceum. These three forms the Vogt triad. And the other question is, which of the following is not usually associated with tuberous sclerosis? It is nothing but adrenal pheochromocytomas are not usually associated with tuberous sclerosis. Renal angiomyolipomas, lymphangiomatosis, and cardiac rhabdomyomas are usually associated with tuberous sclerosis. So remember epilolia, that is Vogt triad in tuberous sclerosis. And also this is other case, 20-year female with foot drop and difficulty in walking and gradually progresses since 1 year. So what is the diagnosis? So it is nothing but limb girdle type of muscle dystrophy or type 2. Here you can see there is nothing but selective atrophy or fatty replacement of the adductors and posterior thigh muscles, which are typically seen. And also in this entity there will be bilaterally marked fatty replacement of the pelvic muscles, especially the gluteus medius maximus muscles, the obturator and the iliopsoas muscles. This is mostly present in the adolescents, and it is autosomal recessive inheritance, and typically there is calpain 3 mutation which is located on chromosome 15. So this is nothing but a limb girdle muscle dystrophy type 2. So other differentials like differential diagnosis can be Duchenne muscular dystrophy. So next case, 35-year-old male patient came with complaints of chronic headache, seizures, hearing, visual disturbances, and severe abdominal pain. You can see there are multiple cysts noted scattered in the pancreas, and also multiple cystic lesions noted in the kidney, and also few altered signal intensity areas also noted in few of the cysts. So by this history and diagnosis, definitely you can suspect von Hippel-Lindau disease. So what is the most probable diagnosis is one Hippel-Lindau disease. What other screening is usually done to confirm the diagnosis? It is brain and spine screening to rule out hemangioblastomas. And when you see hemangioblastomas in the brain or cerebellum, definitely suspect drop metastasis. So you have to screen for the spine. What is the most common cause of death in this patient is renal cell carcinoma, specifically of the clear cell subtype, which is which develops within the cyst or adjacent surrounding parenchyma, which occurs in 70% of active individuals by the age of 60 years, which is the leading cause of death in VHL. Here also you can see this can be a RCC which is developing in the pre-existing cysts. Next case. Here you can see there are two radiographs which are given to other. First one is adult abdominal pain. There is no history of recent diagnostic barium studies. This is child with abdominal pain, and there is no history of recent diagnostic barium studies. But in the both radiographs you can see commonly there is a radio-opaque substance noted within the bowels. So what is the radio-opaque substance when it comes in adult, and what is the radio-opaque substance when it comes in the child with no history of previous diagnostic barium studies? So here A is nothing but bismuth antacid ingestion. You can see there are multiple bismuth which can be seen as radiopaque substance noted in the bowels. This patient has been drinking copious amounts of Pepto-Bismol for abdominal pain, which is nothing but bismuth subsalicylate. The bismuth is a crystalline metal with high atomic number, that's why it is radiopaque. And second case, it is nothing but you can see multiple radiopaque like substances noted throughout the bowel. So it is nothing but geophagia. It is commonly seen in child, pregnant women, especially in psychiatric patients. Geophagia is found more commonly in iron deficient patients despite worsening iron deficiency regardless of the soil iron content. Geophagia also seen in lead poisoning. So this is a case of bismuth antacid ingestion, and this is a case of geophagia or pica. Next, what is the surgical procedure done here? What are the indications and what are the complications? Here you can say this is nothing but a psoas hitch procedure. Here you can, this is a psoas hitch procedure, and one of the other counterpart is Bori bladder flap. Both are done in case of ureteric reimplantation. This is nothing but a ureteric reimplantation following distal ureteric resection. So whenever there is a distal ureteric resection, either due to injury or cancers, whenever the distance of the ureter is short, when the ureter cannot be implanted in at the level of to the bladder, then the bladder is pulled up and nothing but secured to the psoas muscle, and so that it decreases the distance between the bladder and the resected ureter. So this is a procedure which is done for ureteroneocystostomy. What are the complications of the procedure? Which is urinary leak, strictures, and vascular compromise are the common complications. So psoas hitch or Bori bladder flap are nothing but ureteric reimplantation techniques. Coming to the last case. So this is what is the diagnosis? Name the class of Muller-Endrich anomaly. Mention two pathological conditions where it is seen. So this is nothing but you can typically see a T-shaped uterus. You can see this is the T-shaped uterus. Name the class of Muller-Endrich anomaly. It is Muller-Endrich anomaly 7. Mention two pathological conditions where it is seen. It is nothing but diethylstilbestrol exposure seen in 31% of exposed women, and adult women with severe estrogen deficiencies or chronic OC pill use. In these two conditions, you can see T-shaped uterus, which is nothing but Muller-Endrich anomaly 7. Thank you all.